Here we go. Okay. So again, good morning, because all of you are from East Coast here. As Sushilji introduced me, I'm Dr. Raj Shah. I'm a cardiologist here in Philadelphia. And I have, if I may say, passion to incorporate technology for healthcare delivery. And that has been a passion for almost 50 years, right from my training days at UPenn. Of course, we didn't have too much technology then. Only thing we had was a trans-telephonic pacemaker transmission and a TI-10 calculator. So from there, we have grown, and I have continued my journey. And in 1995, it so happened when I was doing MBA, that's when World Wide Web Netscape browser was introduced. And I said, how I can leverage that for seeing patients and healthcare delivery. So with that, I was fortunate. So technology, which is passion along with medicine, I was connected with this phenomenal group under our president, Suresh Shenoy and Hitendra Ghosh, the Wills Global Foundation. So I'm going to sort of start with Wills Global Foundation and take you through this journey. I'm going to do the screen share and bring the first slide. So you can see me, and I think you can see this slide. Can you?
Yes, yes.
Okay. All right. So let me take this out from here. So Wills Global Foundation is a Pan IIT alumni, which is a 50,000 plus IIT graduates who started this non-profit charity organization with the inspiration from then President Abdul Kalam, who himself was a great scientist, a technologist, and he inspired to say all IITians, and for that matter, all medical graduates, we all have been educated, and which is the one of the most important reason for our success. Our education was greatly funded by taxpayers of India. IIT is Indian Institute of Technology, and all medical schools, all hospitals where we learn, it is always with these great subsidies from government. Otherwise, my total cost of getting my medical degree, entire education, if I put it in terms of dollars, was less than $500 for the whole education. And that would not have been possible unless we were subsidized by taxpayers then. And therefore, we do owe to our people. Of course, what we have earned is from the community here. So we also owe them, but we also owe that to our country which help us to get educated. And with that, the WILS was started. And the WILS actually acronym stands for water, health, energy, education, livelihood, and sustainability. In these 6 sectors that WILS will concentrate, and they will, and the guiding principle will be that you bring technological or technology-enabled solution for what you want to do. So it's really not kind of a free charity organization where we'll just collect money and give it to people. No, we will get the charity, we'll get the funds and use that fund to find out a technical solution to existing problem. And particularly, most of the things which is really needed is in rural communities. So WILS, all the sectors kind of concentrate right now for the rural communities, water for rural communities, healthcare for rural communities, energy for rural communities, education, livelihood, creates jobs and sustain them. That is the guiding principles of WILS Global Foundation. And under the health, I formed a council and I'm the chairman, along with patrons being Rajat Gupta of ex-McKinsey, Arjun Malhotra, one of the founders of HCL, Anil Bhandari, who is one of the hedge fund. Uh, all of them are, all of these are majority IIT graduates. Only and there are few exceptions. Hitendra Ghosh, who is one of the founder and one of the earliest IITians, graduate of 1958, along with executive members being Dr. Vikas Khurana, he's a gastroenterologist, Dr. T.G. Patel, a very illustrious, from my alma mater, a year junior. He retired as a captain from US Navy. Dr. Ashok Gupta, he's Padma Shri in India, and Amit Khare, he's the CEO of the technology company. And of course, Suresh, being president, is our ex officio member along with Digvijay. We have a Wills Global Foundation India. So this is our Wills Global Foundation. And just in last a couple of months, we aligned ourselves to FIPA, which is Federation of Indian Physician Association. There are about 2,000 physicians who brings in the physician aspect of the healthcare. Of course, healthcare is being delivered by physicians, so that's an important um, uh, alliance. Shivyog. Shivyog is a foundation in India and also here in Silicon Valley. They are concentrating on mental health and mental health through meditation and yoga. And they have these classes. So I want to introduce uh, mental health along with the overall health picture. And as I always say, people forget that the health is not just the absence of disease or physical health. Actually, in 1950s, the health was defined by World Health Organization as the state a state of physical, mental, and social health well-being, not just the absence of disease. So even the poverty removing poverty is also taking care of the health because that tremendously affects the health. So we brought Shivyog, they are aligned with us. And recently we are working with Ekal Foundation. Ekal, I'm sure many of you are familiar, and Suresh, you were just mentioning about ECOL. They are one of the most successful NGO doing phenomenal work in education. They have created schools in 130,000 villages, and it runs on charity. And that's one of the most successful, along with Akshay Patra. So uh, kudos to them. They have done phenomenal job. Now, so let's get to when we started the Health Council. We took one as a mission is what can we do? We don't have deep pockets to open charity clinics or hospitals or go and provide the care. And where we can bring technology. So I said, most important thing we can do is access to affordable healthcare. There are villages, 600,000 of them in India. Many of them forget about the roads or infrastructure or internet or anything. They don't even have a doctor or a clinic or hospital within like 15, 20 kilometer. So these rural communities are greatly underserved because they don't have enough doctors, clinics, hospitals. They don't have infrastructure, and they don't. And of course, their income is less than $2 a day. So it's really all the problem of healthcare is exaggerated by poverty, lack of education, and awareness. But we can handle all of this. At least we can do something so that they have healthcare accessible. Now, we are not going to be able to create clinics for them in every village. We are not going to have doctors go to them. So how do we do that? So here comes the technology at the rescue. And the reason I'm always such a passionate about technology, that if you look at the history of mankind of last 10,000 or 15,000 years, mankind has progressed. Every step is because of technology. Otherwise, we'll be living in Stone Age. We won't have fire. We won't have wheels. we won't have water, we won't have agriculture, we won't have anything. And of course, in last 50 years, with phenomenal progress in the digitization, the microchips and computers has completely changed the world. So technology is at the core, at the roots of every progress made in our life. And medical sciences are no exceptions. What we are doing, and I can tell you, the medicine I learned 50 years ago and what I'm learning today, 90% of that didn't exist. CT scan didn't exist, MRI didn't exist, computers didn't exist, bioengineering did not exist, the ultrasound did not exist. Many of the medications we have did not exist. I'm talking about me who studied this 50 years ago. So I entered medical school in 64. So at that time, only invention known, modern invention, was the Watson and Crick determined the structure of DNA, double helix structure, in 1962, and they got the Nobel Prize. Nothing happened till 2000 for more than 40 years, till computer helped us to determine the structure of genome, and look at what has happened in the last 20 years. So it's just unbelievable progress, and thanks to all the technocrats. So I always salute, and that has been a passion to learn more and bring that into what we are doing. So I came up with this idea. Of course, I had done this healthcare over past 20 years plus, when I created a freestanding telemedicine clinic, which was first debut into Walmart store in 2012. I ran it for 2 years as a field, or we can call pilot. So more than 1,000 patients presented the data. We got the first prize in 2017. And I've been working on, and that's my program called Smart Care Doc. It's only for USA. I don't have the infrastructure to do it in India. So we are using another very, very versatile system, and I'm going to show that to you. So we created healthcare easy access for rural communities via telemedicine, called HEART, of course, cardiology, or heart being at the heart of my passion. So I call it a heart center, and it was created to deliver telehealthcare. Now let's see, what is telehealthcare. Of course, if you just decipher the word tele prefix, it means distant. Anything which you are doing from distance is prefix name with tele, like telephone. We are listening to the sound from distance. That we are doing for last 100 years or more. When Graham Bell showed the telephone first time in Philadelphia during the first World Fair. So we are talking to patients, we are listening to their complaint and giving them advice. That is telemedicine. Only thing is, in last 20 years, with the video becoming easily available, we have added the video component. So now we, in addition to listening, we are seeing the face. So that is televisit or televideo. Um, uh, uh, we are using television, we are using telemetry, we are using telegraph, telephone, everything. So anything we do from distance is tele. So really, telemedicine is not a new science of medicine. It is simply a tool which allows us to connect with the patient from distance. And that has tremendous advantages. And those advantages for patients are it. So we now don't need to build hospital or clinic or ask doctors to go to those villages. We can bring those doctors remotely to connect with patients and provide care. And that allows patient to sort of avoid the travel, loss of wages, loss of productivity, make it convenient, eliminates distance and weather barriers. And because of this, since we are, if you consider this is like a Amazon model without brick and mortar and the facilities, we really lower the cost of providing the care. So we lower the cost, we make it convenient, and we still, because we are connecting with patients, seeing indirectly to them, we are providing quality care. And for doctors, really speaking, if you think those who have visited doctors in last, let's say 5 years, when you go to see doctor, actually doctor is looking at the screen, you are seeing his back and he's talking because he is picking in the information. So we have lost the face-to-face contact. But now, if you're on video call, you have to see and talk to the patient. So it's really better. It allows doctors the flexible hours. You don't have to be in office. You don't have to be in a location. It saves your travel time. It expands the practice. And those who want to do some extra work in downtime, it also gives them income. So overall, when we bring telehealth care, it has all the benefit. Of course, I'm not here to say that taking care of patient from distance eliminates the in-person care. There are many conditions where you have to be in person, that you have to bring the patient in. You need to examine. It's hands-on. If you have to do any procedures, you have to do it. But there are many conditions, and believe me, 70% of medical condition where, let's say in America, we spend close to $1.5 trillion can be handled on telemedicine. So that is the power. So telemedicine is a supplement which helps doctor to deliver care for certain condition. So those are the benefits that we get. Now, how WGF, we created this program called Heart Program, and there are certain guiding principles that WGF members, they do not have the footprint and somebody actually in the village. So we collaborate with a local representative organization, NGO, that will help us to coordinate and supervise the project. We also create a center where there is at least, it serves a population of 3 to 5,000, because then it becomes cost effective to create this thing. And if village has only 500 people, then we take cluster of villages, maybe 4, 5, or 6, which are within the walking distance, and create the center. We select the resident of the village, of the community. Nobody goes from outside, they're the resident. We choose one male and one female with some basic education. They do not require medical degree. They do not require any specific medical education. I'll tell you why. Because the software has the AI built in so that they can do the job essentially of entering data. But we have two people and they get their salary, and I'll show you how that program works. So we create two jobs also. Uh, we work with the organization and establish a short-term and long-term goal. Short-term is we start the center, we give them 3 to 6 months, see how it is doing, and then we start with maybe minimum anywhere from 1 to 5, and then our plan is to extend to 25 to 30. So that's our short-term and long-term goal, depending on the success. If it's not successful, not utilized, we can stop that center and move it to another place. Telemedicine system will be implemented, supported by our technology partner, Evolco, and I'll tell you a little bit about Evolco in next couple of slides. And of course, the wheels will monitor, measure outcome and impact, and produce these results. So let me share with you the system that we will be using. This system is developed by Evolco, which is one of the founders is Arjun Malhotra, who is our patron and founder of Wheels. They are giving us this at cost. So they have done it in India. They are operating more than 500 centers. They're operating more than 500 centers. They have done more than 8 million visits in last 5 years. They are connected and doing work with AIMS, All India Medical Research Institute hospitals, and they are our technology partner. They have the program which operates on the smartphone. It is in 12 languages, and they have ground force of more than 300 people who can actually go to the villages. There are about 8 regional directors who actually take care of the things right at the village level. So they are a very critical technology partner. We use their services. As of now, we started in January. We created 6 centers in Andhra Pradesh, Anandpur district. We have already seen more than 1,200 patients in last 2 months. It is going very well. We created 6 centers, not 3, in Maharashtra, but they are ready. They are ready to go, but because of the lockdown last month, they have not operationalized, but they're ready to go. We have about 4 centers in Gujarat and 2 in Lakhimpur. These yellow are the centers by Wills initiated. Other are they are doing for profit. They charge patient, and they have about 400 centers like that. So
Dr.
this,
Shah,
yes,
what
sir.
about Maharashtra? Where all in Maharashtra?
Maharashtra, they are through Bhakti Vedant Hospital in four villages. I don't remember the name, but there are 2 in Pareli, and we are working with Pune Rotary Club and Cisco chairman, Mr. Rajesh. I forgot his last name, Rajesh, uh, and they want to do more centers in around Pune. Okay, so there are 10 villages in Maharashtra.
Anything in Aurangabad?
It is near Aurangabad, yes.
Yeah, okay.
And it is through Dr. Rajkumar Tripathi, who is a physician in Mumbai.
Got it.
Okay. So now the software that we are using, it is in, as I said, in 12 languages. It has most of the common 300 plus symptoms, and on each symptoms it's an algorithm built into. So if person says I have fever, it will automatically ask the subsequent questions which doctor will want to know in yes no format. So it builds up the information. Then we provide the devices which they can take the vitals, blood pressure, pulse ox, temperature, single channel EKG, etc., blood sugar. So this thing is done before doctor sees the patient. It also includes the demographic, the diet, physical activity. So it's really a comprehensive information collected by the we call TMO or telemedicine operator at the village level, who has a phone and has the devices. They prepare this, and then doctor gets a message, and doctor connects with the patient either by phone if they don't have good internet or video connectivity, or by video, see the patient, prescribe the treatment, and this is how each visit is occurring. There's also a way, this is just to show you different screens. As patient give information, it goes one after another, and at the end it builds up a very nice report which doctor is able to see online, or it can be printed and given to the patient. We also make arrangement automatically. If patient is healthy and only need annual check, then there's a reminder built in. So after 1 year, there'll be a reminder to the patient for their checkup. Same thing for every 6 months or quarterly, depending on patient's health condition. Some of the commonest disease like diabetes, heart failure, anemia, maternal and child nutrition, all these diseases can be very easily treated and monitored using telemedicine. This constitutes more than 50% of the disease condition that we deal with. And I told you about these centers. Now, we also, it not just one visit is done, but the Evolco, through their ground forces, there's automated reminder system. Even operator can initiate the visit. They can check any missing details. There is an ongoing quality and compliance through regulation according to the Indian government. Administrative reports are available on the dashboard to the admin. And we'll be constantly doing quality analysis matrix and outcome measurement as we go along. We'll also continue if there are any technical difficulties, 24/7 services provided, and everything is looked. So it's not just one visit, but everything ongoing with the people at the ground level through the 24/7 support. And the way project is implemented, we select the person from Evolco actually goes, select the operator, one male, one female, train them, train doctors. And when we say telemedicine center, it's really, it could be that person's house, or that person in a small bag can take it and go to patient's home and provide the care. So there is no infrastructure needed. And of course, once we select the site, we get we have a health fair first time, invite everybody, give some basic health checkup, and make them aware this facility available, and then the it get operationalized. So this is our modus operandi, and the way it works is how what Wheels does, and how we make it possible, and how we have created a financially self-sustaining model. So when we look at it, we have two costs. One is an initial hardware cost, which is one time, and then we have ongoing cost, which is variable cost or operational cost, if I may put. The hardware cost, which requires two sets of a smartphone with the SIM card, and the devices like infrared thermometer, pulse ox, blood pressure scale, glucometer, and single channel EKG recorder for the rhythm. So these are the basic kit. We also have ability to add stethoscope, 12 lead EKG, and ultrasound depending on the need where we are setting up. But this is our basic kit. The basic kit, uh, uh, two sets cost $1,000. That's upfront cost, and that is donated by Wills. So Wills donate one time $1,000 to create the center, and when we give this $1,000, not only kit, but Evolco includes in that money. They go to the site, they train, they set up the things, and continue monitoring. Now, after it is set up, then for every visit, it turns out that the basic cost right now, for example, Evolco provide this service as a fee for service, and they charge 250 rupees. But for our Wills Global, you can call it part of the service or donation, they provide us at a cost. And at a cost, it is 110 rupees. And let me tell you, which is equivalent to like $50. In this 110 rupees, there are three variables. One is a doctor's fee, which is about 50 rupees for 10 to 15-minute consultation online. Then we pay 30 rupees for to the telemedicine operator who is there in the village and doing this. So that pays their salary. And then we collect 30 rupees for the maintenance and support of the software, consumable, and ongoing maintenance. So this 30 rupees goes to Evolco as a cost that we pay on per basis. Now, it is possible that patient will pay 110 rupees, but if there is organization like hospital, and this is what we did with RDT when we started. RDT is a Vincent Ferrero charity foundation which runs 3 hospitals. And the doctor said, and they serve almost 6,000 villages in that district. And they say that our villagers, even though they provide free care, those villagers have difficulty traveling, coming to the hospital to receive the care. Sometimes they have to stay overnight. And it costs them anywhere from 500 to 2,000 rupees to receive the care. Care is free, but this is the cost to the patient. Now, they have decided that they will give free service from the physician. Then patient does not pay this 50 rupees. They also have volunteers who want to go to those villages and provide a service. Then patient does not pay this 30 rupees. Then patient only pays 30 rupees. And they say, well, organizations say, we will write up the whole cost, then patient pays 0 or maximum 110. This is how we are sustaining ongoing operation after initial setup. And it provides access to patients and really cuts down their cost from usual 500 plus to 110, almost one fourth or one fifth. So that is our model. This is how we have done. And I'm happy to say at this stage that during the COVID, and let me, before I go to that, let me just tell you how this becomes self-sustained. So what Evolco charges for software and other thing, as the number of visits increases, that their marginal cost goes down. And as a result, they have promised us that 10 rupees from 30 rupees they collect, they will donate back to the WGF. And this money, when WGF gets back its donation, will help our cost of running the program, as well as there'll be money left to start new telemedicine centers. So just to give an idea, if we have 100 sites with a ramp up analysis in a year, an average one telemedicine operator and in a minimum level will do about 10 visits a day. And each visit takes half an hour. So it's just like a 5 hours work. Normally they'll work 8 hours. They usually do more than that, but the analysis or projection is based on 10 visits after 3 months of ramp up. And that gives us about 127,000 visits if we have 100 operating sites. That's in rupees, and if I convert in dollar, it'll give us about $17,000 just to back to the WGF, of which if we may have some administrative cost, that leaves me $13,000. I can now open 13 additional sites. If I create 500 sites, I will have enough money left and remaining. These are self-sustaining, ongoing, no other donation required. So I can create another 100 sites and go there. And if I have 1,000 sites, I will, every year I can open almost 300 more sites, which will be kind of have a tremendous advantage of self-sustained, self-supporting, and self-sustained growth model. With this presumption, we may be 100%, we may do better than this, or we may do worse than this. But in any case, we will continue our operation, and we can have this in go. At end of the day, villagers who do not have access to healthcare now are able to see and receive care. That's the mission. I think we can make it successful. Now, coming to something happened during COVID emergency. So that is how we started. We outlined the program in November. We kind of got our board approved in December. We started in January. In less than 6 months, we have done a phenomenal progress up to March. Come March, April, with the COVID second wave, we changed our modus operandi. We say, look, right now, patients need to be seen, and patients do not have money. We cannot do that. So let's do charity. So we changed our model. And we are happy to say that during this time, we got tremendous the call. Those who knew a little bit about our system and those who really wanted to help, they poured their heart, and we collected almost close to 300,000 a donation, some of them targeted for healthcare. So we got money, and now there is a great need in Uttar Pradesh. We are opening 200 centers, cutting down the cost in just getting the minimum devices, temperature, pulse ox, scale, and blood pressure with single smartphone, because during this time we don't need the complete, and with this we are able, in a $500, we are able to open one site. And Evolco says they will provide completely free service. They'll provide physician. Evolco has about 200 plus doctors on that panel. Some of them are salaried. They'll provide free. They will provide operator in each village and pay the salary, and they will provide and not charge. So Evolco on its part providing this as a charity. So patient pays nothing. in just $500. That's why I'm able to open 200 centers in Uttar Pradesh. And I'm talking with, there's a tremendous need in Bihar. And I have, I have to get approval from our president. Uh, I think we have enough money to open additional 100 centers in Bihar. So at the end of the month, we will have close to 350 centers which will be operating. And after COVID, we will then make it a full-fledged centers and then start working on a self-sustaining a small fee model. And so my goal, which was to have 500 center by end of 2022, I'll probably reach 1,000 centers by end of 2021. And that is the thanks to the generosity of many people who have liked this idea uh, and help us to get there. So now during the COVID, as we see, we have sent, we had money, we sent about 200 we opened 200. Now we about 300 centers will be opening. We have sent life-saving equipment, oxygen concentrator, BiPAP machines, etc. At 500 each, total 470. This has been supported by Wheels. Wheels has also supported close to the $80,000 donation to IIT, three IIT institutions to accelerate the design and manufacturing of low-cost oxygen generators and rapid COVID testing. Uh, we also have donated to Aadhar Shila, which serves the slums population in Delhi, started by Delhi IITians, $25,000 for to buy oxygen concentrator and create personal hygiene kits, basic supply, the soap, the disinfectants, the socks, the mask. These people have nothing, and that's what is given to them. So we have already done this, and now I'm looking for, I want to create 1,000 sites. I need $400,000. I would like to distribute more kits to people who have nothing. Another 4,000 kits. We have done 1,000. Another this 75,000. And another important thing: every telemedicine officer could be our person to make people aware of COVID testing and vaccination, which is a tremendous need. We can make them do by giving them education posters or pamphlets and or spoken tutorials using video. Professor Kanan Mogdalia at Bombay IIT, he is master at creating this, and he will help us. So with this, I'm looking for getting 500,000 is my target by end of this month, and let's see where we reach. So that's where I come to people who believe in technology, helping to do a solution in healthcare. This is how we can do it. This will be great use of your resources. It will continue and keep supporting, literally say, ongoing for ever and ever and ever. Of course, there's nothing like ever and ever, but it is a good chance that it will be a self-sustaining. Once we have the data, we'll produce this, provide this every 6 months in the government accepted social enterprise for a human upliftment model. All the data that we'll be collecting, we are already collecting. These are the 6 villages in up to January in Anandpur district. This Dormelag, Gangapalli, this. So we track everything. We track what kind of services there we utilize. We track what kind of common conditions that we are looking into providing care. So this is all ongoing. I'm happy to say that Sushil ji has joined our Health Advisory Council, about almost 30 members from all parts of the technology, the entrepreneurs, business people, accountants, doctors, visionaries, IA government or ex-government officers, etc. So with their help and guidance, we are constantly evolving and improving our modus operandi. And when I finish, I ask that at least you can do more than one or as many, but adopt a heart for a village. And we all come, our roots are always in village. We can create the telemedicine center. We can give the name if we want and create this with $1,000 donation from each. That will be, that will have a long lasting appeal and positive things that you will contribute. So I know we only have few people, but I know all of you have great network. And if you can take this message and help us to raise, my goal is 500,000 by end of this month. I also want to just bring it to your attention that we have collaborated. We have given seed money to NYU School of Global Public Health. They will help us to analyze our data and put that as a part of the public health school student curriculum to introduce telemedicine and its implications. We are also working with University of Utah Center for Medical Innovation to do the device testing, research and development in cooperation. So these are some of the activities of Wills. And I think at this point, I will kind of stop sharing and see if we can discuss and have a dialogue to hear from you.
Your reactions, Koshi, Suresh?
Yeah.
Can I ask you one question?
Yeah, go ahead.
Sure.
You said that there is an automatic reminder.
Yes.
How do you do it in a village where there is no social security number, there is no address, there is no, I mean, I may be wrong on this because I don't have direct contact with any village, but I believe that